Okay, so good evening to everybody. I am Cosimo Pieri from Europa Uomo Europe and also part of the Europa Uomo Italy Association. What is active surveillance and which benefit come from active surveillance? With this webinar and the following ones, we want to give a basic introduction of active surveillance, benefit to patients, overview of their journey, limits of application, and in particular where to find in-depth information. Also, it could be a good idea to motivate us to create a new opportunity for communication between patient, medical staff, and the association. Since more, let's say, than 10 years, Europa Uomo Europe and their affiliate association 27 is committed to support men with reliable information on prostate pathologies. And in specific, we can quote early diagnosis, multidisciplinary approach, and quality of life. Active surveillance we have to say that is not for all prostate cancer patients, but we have to say that in the cases where medical specialists confirm that it's safely applicable for specific patients is a very logical choice. And this is also what we discovered recently when Europa Uomo Europe did a big survey on quality of life in November 2019 on 3,000 European prostate cancer patients that were answering from all the 27 countries all over Europe. The average of age of the respondents was around 70 years. 64 years were the average age of the age of diagnosis. From this survey, there were many indications for all PC type patients and all type of treatments. And you may have a clear review of this in the video presentation that is in our website, Europa Uomo, and is called EU-PROMS. The important thing we want to say today on this specific item about active surveillance is that one of the take-home message that we got was that to ensure the best quality of life, active surveillance should be the first treatment considered if the low grade and specialist confirm applicability to the specific case. Indication confirm good quality of life in our survey. So having said that, I would like to introduce you to Professor Hendrick Van Poppel, which is the Adjunct Secretary General in the European Association of Urology, specific for education. He's co-founder for Europa Uomo and the chair of the Scientific Committee of Europa Uomo. Hendrick, how are you today?
Thank you, Cosimo.
I'm
doing well, and it's good to see so many people around that are doing well as well in these strange times. And I'm very happy if Anya can allow me to share my screen.
Yes, and in the same time, we have prepared some questions for you, because so in general, if you can explain us something about active surveillance, how this allow to delay treatments, how urologists find out if it's safe for a specific patient, the impact of quality of life, and difference from watchful waiting. A lot of questions, but certainly you will be able to go to explain us briefly these things.
Okay, thank you, Cosimo. And by the way, I just want to thank you on behalf of everybody because you have taken the initiative and you have got this off the ground to invite me, invite Monique, and we're very happy to be able to do that today. Excuse me. I'm going to do that better. I just heard we have a couple of people from different countries throughout Europe. And as you might expect, there is a vast majority of prostate cancer patients in Northern and Western Europe. Mortality is here in red. If you look, I would expect Southern Europe to have even less prostate cancers. You see there's less prostate cancer that as well. And then there should be fewer in Eastern Europe, while I doubt that there is something wrong with reporting of prostate cancer in these countries.
Hein, I do not see your screen, but perhaps that's only me, but I don't see your screen shared.
And are you the only one?
No,
No, we don't see the Hendrick. We don't see it.
I don't see it either.
Okay, thank you for telling me.
now.
Do you see
Now
it
it's
now?
coming. Now, yes.
Yes.
Okay. When something is wrong, you really need to tell me, because I only see the screen in front of me here. But today we know that 1 out of 7 men in Europe will develop prostate cancer, and it's the most common male cancer in the European Union these days. And I give just an example. In Germany, prostate cancer today kills more men than colorectal cancer does. In the UK, more men die from prostate than women from breast, which is not the case yet in Germany, as you can see. Now, when we speak about active surveillance, the issue is I have cancer, but I do not need treatment immediately. Where does the idea come from? And this is an old study from Sacker in 1993 already, and they were looking at autopsies from people that died, men that died in a traffic accident, and they looked at their prostates histologically under the microscope. And you see already in very young men, there was a small percentage that had prostate cancer microscopically, and this is rising at the age of 70 to 80, up to 83%. This means that men at 100 years of age, they all have some prostate cancer present in their organ. And you immediately understand, if we would find all these cancers and we would treat them, we are doing far, far too much. Now, do not forget that prostate cancer, although it is not killing like, for instance, pancreatic cancer, like lung cancer, and there is incidental prostate cancer in the general male population at autopsy in more than 50%, do not forget that the tigers, the bad ones, are responsible for 11% of all male cancer deaths are thus prostate cancer related, which is enormous. And we need to do something about it. But this makes also that we are feared about prostate cancer, because it is still a killing disease. It's not the disease of old men that die with it instead of from it. And this has to do with the differentiation of the tumor. A tumor can look very much like normal parenchyma of the prostate, or it can be very aggressive, where you hardly can recognize that this is prostate. And this is the different Gleason, Mr. Gleason has made this classification from 1 to 5. And a pathologist, he will say the 2 most common grades in the specimen that he sees, in the biopsy or in the radical prostatectomy specimen, is, for instance, grade 3 plus grade 4, and this will then make a Gleason score of 7. Everything that is above 7 is bad. Gleason score 8, 9, and 10. Everything that is below 5, we do not even consider this to be cancer any longer these days. It's not even mentioned in the pathology reports. And then there is an intermediate group, scores 5 to 7. Actually, today we say 6 and 7, under condition that this is 3 plus 4 and not 4 plus 3. You understand the difference. When the majority is Gleason 4, it's obviously worse than when the majority of the tissue, malignant tissue, is Gleason 3. Now, if we do not treat prostate cancer and you are young and you have a Gleason 8 to 10, the likelihood that you die from prostate cancer is about 100%. If on the other hand, you are older, 70 to 74, and you have an intermediate Gleason you see that the likelihood that you die from other causes is much more important. It's 3 times more than the likelihood that you die from prostate cancer. So you immediately understand that if we would treat all these people, we are over-treating, obviously. Now, by using different techniques for diagnosis, you see that there is an increasing incidence of low risk at diagnosis. Also for intermediate, and the high risk is actually decreasing by time over the years. And this is the consequence of PSA. PSA was introduced in the early 80s in Europe, and you see that what was the immediate consequence by PSA testing is a high number of more cases of prostate cancer were detected. So we have diagnosed people that some of them did not need to know that they had prostate cancer. But by doing so, by doing this overdiagnosis, we have achieved something as well, because you have seen the decline in prostate cancer mortality a couple of years after PSA was used. You don't hear me say that this is due to PSA only. It's also due to the better treatment, obviously, we had. And this is great if the treatment should preserve quality of life of prostate cancer men. But it impacts on quality of life. And now I come to the question that Cosimo just asked me. Treatment of early prostate cancer can result in problems with continence, erectile potency, and bowel function in the case of irradiation. But treatment of too late diagnosed prostate cancer needs hormonal treatment, chemotherapy, castration with very poor quality of life. And you understand that when I go back to my early career in the late 80s, we wanted to avoid advanced and metastatic prostate cancer. And we treated men who did not deserve any treatment yet. And I know from the 3,000 and more radical prostatectomies, in the beginning of my experience, there is 10 to 15% that did not need treatment at the moment that I took their prostate out. Because I and my colleagues, we were unable to discriminate between significant and insignificant cancers. But in retrospect, when I look back at my Gleason 6 radical prostatectomies, what did we see? They did not metastasize and they did not kill any patient. So we have had overtreatment and overdiagnosis. So there must be a possibility to recognize which patients could just be observed without treatment. And this is what we call active surveillance. But this indeed means you are under surveillance. This is not nothing. You need regular monitoring, doctor visits, you need to have a delayed invasive treatment if there is tumor progression. But it's the only strategy to diminish the overtreatment of minimal cancers that we professionals have been blamed for so many years. It's not watchful waiting. Watchful waiting, the difference is we do not do any treatment until the patient gets symptomatic. And when he becomes symptomatic, we just give palliative treatment. Now, there is an increased use over the years of active treatment, and you see it here in red, that's increasing. Luckily, for low risk, ADT is less and less given. Still in 2009, far too much. This is a disease that should not be treated with hormones. There is still an increase in radical prostatectomy and radiotherapy, but active surveillance over the last 10 years has continued to increase. And then the question immediately is, does active surveillance impact on quality of life? If you do not give treatment to a cancer patient, there is a risk that the cancer progresses. And this induces fear and psychological effects. And a lot of patients will at some point want to be treated by anxiety because there is an objective progression that we need to detect on the hand of PSA increase, PSA velocity, MRI, eventually biopsies, where we will then say, now we stop active surveillance, your tumor is growing too fast, it's too dangerous, we will do something. And at the time of this delayed treatment, after active surveillance, there may be a decreased likelihood of cure, or the treatment needed might be more aggressive, leading to more incontinence or more impotence. So there is something that will play in the man's mind when he chooses or he agrees for active surveillance, that these are things that can happen. But quality of life, as shown by your team in Europa Uomo, is best when a patient is on active surveillance. It's better than when they have radical prostatectomy or radiotherapy. It's certainly better than when they have androgen deprivation therapy. And it's absolutely much, much better than patients that become castrate refractory and that got those treatments. And you see that over the years, more and more men with low risk and intermediate risk have chosen not to be treated immediately, but go on active surveillance. But is it safe? And during the coming webinars, you will see more recent data, but this is from the PROTECT trial, comparing surgery and radiotherapy that are around here. And this is patients on active surveillance. Disease progression occurs when you do active surveillance. Obviously, the tumor can progress and might become dangerous in the end. So the other question, how do we detect the cancers that might be amenable for active surveillance? The most important is the information of man. Man need to be informed, and we have in the EAU this information, should I have my PSA tested? And there is immediately a need in this patient information to tell the patient that what is his risk for having prostate cancer. And when he finally has prostate cancer, that it might well be that you're not going to treat him. Because if the patient does not know that beforehand, he will say, you detected cancer in my case, and I want to have treatment, I want to get rid of it. But he must understand from the beginning, from the initial information, that there is a likelihood that he can go on active surveillance. And I will not go in detail on the rest of this nomogram, but there is risk stratifications possible. We have MRI, but a group of people will have cancer and will not need treatment. And that's the important point. I know that Cosimo wants to know that I would highlight how do patient organizations interact with the EAU? Well, we interact very, very much. And the Europa Uomo board and executive people know that we support their activities in a substantial way. Europa Uomo is a member of actually all the cenacles we have. There's the patient advocacy group. Patients are involved in EAU guidelines. I just saw Eric Brees participating in the patient information, in our publications, in the annual congress, and in the policy activities. We are not good to talk to politicians. We need you to talk to politicians and say, we want you to make that our urologists and our experts do what is correct. And this will be active surveillance in a number of cases. And so we have made this white paper on prostate cancer with the help of Europa Uomo and EAPM. And November, we have had this European Prostate Cancer Awareness Days that were initially also put together with Europa Uomo, the help of EAU, while we are now working together on this. So how can we eliminate the second most killing cancer without having any problem and not forgetting that there is active surveillance? We need to use PSA properly, and we should treat actively with radical prostatectomy or radiotherapy those at risk to die from prostate cancer, and manage with active surveillance those with low and part of those with intermediate risk. And this will decrease the cost of prostate cancer, decrease the mortality, and improve the quality of life. So I hope I didn't make it too long. Thank you, Cosimo. Thank you for all your attention.
Thank you very much, Eric. For me, it was very good. In any case, I want to say that we are able to answer the question if you want to put something in chat at the end. But we are, as we said at the beginning, the idea is to establish more communication between all of us. So if we don't, if we want, we can answer also later. We can discuss later as we better. Now, as we agreed to make something effective, I will give a testimonial. In this case, I am the testimonial because I am as active surveillance prostate cancer patient. And so what is my experience? now that I am 69 as a PC patient. I had at 55 the frequency urinary issue symptoms, so some symptoms. That will give me a reason to meet a doctor, a neurology, with after some examination, diagnosticated benign hypoplasia, so not a cancer, but just prostate was too big. So then there were 4 years of pharmaceutical treatments that in any case could not avoid surgical intervention to reduce the dimension of the prostate. And after this surgical intervention, the symptoms disappeared and everything was fine. So, but obviously the urology advised to continue and to have yearly controls of prostate situation. And in effect, in the 5th year after this, so 5 years after the surgical intervention, the urologist find a suspect nodule and doubled the PSA without any symptoms. So it was something to be taken care. There was immediate, reasonably fast magnetic resonance. And after that, there was a biopsy, a fusion biopsy. Then, let's say, came out the diagnosis of carcinoma, so malignant prostate cancer, low-grade Gleason 3+3. So what we can say, it was, in a certain sense, it was a real early diagnosis because there were no symptoms in this part. And so early diagnosis and asymptomatic situation. Then I want to remind that to present what happened. So the urologist presented 3 choices, and 2 were treatments, and 1 was the strategy. So the treatments were the surgical prostate removal or the radiotherapy. And 1 was the strategical method of control, as we say, as I knew in that moment, called active surveillance. This was suggested as a logical choice. There was no push for one or the other treatment, but together with the urologist, we find out that due to the general situation of the patient, the age, and the grade, which was low grade of prostate cancer, active surveillance could be the most logical choice. Also, the urologist alerted me immediately that there are possible psychological issues that because many patients do not want to keep the cancer inside their body. Here, what I want to say that in this approach, even if it was only one doctor, only one urology, the approach was multidisciplinary. So it was a very good approach, in my opinion, from the urologist because it didn't push in one direction or the other. Now, let's say after more or less 5 years after the diagnosis, the yearly controls go on with PSA, magnetic resonance, biopsies, not every year. The good point is that the prostate cancer did not grow, and so I may continue the active surveillance for the next year. I want to put, regarding the psychological effect, in effect, there are certainly physiological effects that could push the patient to take decisions of treatments, especially when you wait for the yearly controls, especially the first year, because you are, let's say, obviously badly surprised from the diagnosis, and you have 1 year where more or less you control PSA, but you don't know exactly what will happen with the magnetic resonance or the biopsy at the end of the first year. In this case, I think I was, let's say, lucky to find an association like Europa Uomo in Italy, because it gave me the 2 possibilities. 1, to understand more about my choice, because when you have a neurologic visit, it is 15 minutes, 20 minutes. So you don't have a lot of time to understand something that you have never know before. And the second point is the auto help groups, because in our association we strongly support the auto help group. We every week, every 15 days, there is an auto help group. Patients meet together, they speak together. Obviously, there are all type of patients with low grade and patients with more advanced cancer. But it's very good to this. This will have the shared experience, suggestion, so psychological support. What do we want to, before I give this, we proceed with another presentation of the next speaker. I want to suggest that it's important to have a neurological visit after the 50 years, more or less. So, because as you see in my experience and many others, I had symptoms and was not cancer. I didn't have symptoms and was cancer. So it's important to have a visit, because you cannot understand from this observation what is the situation. And the other point is important for patients to be associated, to working, to speaking together and do some action together, because this will help everything to be better for themselves and for the social group in any case. So, having said this, I am pleased to introduce Monique Rubol, which is professor of decision-making in urology in Erasmus and epidemiologist. Monique, we saw already you, but are you today? Are you fine?
Yes, of course. Yes, of course. Well,
we see a very nice
everyone.
picture. We see a very nice picture of your institute.
Yes.
We tried to put together some questions for you, because obviously there are many things to discuss, but we wanted to focus on something. So why and how you planned and this statistical work on active surveillance in Europe? No? What is important to put in evidence from the set of data that you have on active surveillance effectiveness, which are indications for the patient and medical communities? No? And so specifically also patient journey planning, what is the anxiety, possible issues. So we have many questions, but obviously it will give us an overview, and we will have all the time later to discuss more with other patients and between us. So
thank you. Then I will start to share my screen first, right? Just a moment, please. Okay. So I hope that everyone now sees the first slide of my presentation. Is that correct?
Professor Rubol. Yes, correct.
Oh, great. Thank you. Well, good evening all, and thank you for giving me the opportunity to present my work here for you as an audience. And I will talk a little bit about active surveillance, as Cosimo already told you. But he asked me in particular why I am an epidemiologist, as he told me, so I'm not a urologist. So why I work in urology and why I focus on prostate cancer. And that is something that I told a lot about, and especially during my inaugural address some years ago. And there you see the text on this slide. I told the people why I work in this field, why I work in urology. And it is just because it is something that is not discussed openly. Even today, it is something that people prefer not to talk about their urological problems. And in particular, prostate cancer often has a long-lasting, considerable impact on daily life. So this is one of the main reasons why I work for urology, and in particular on prostate cancer. And I feel that it is a privilege to help men to cope with this disease. And I work at the Department of Urology since 1991. So I know everything about watchful waiting, active surveillance, because I've been there for quite some time now. So what I would like to address today, this evening, is a few topics, obviously about the relation between prostate cancer screening and active surveillance, the natural history of prostate cancer and why active surveillance is a realistic treatment option, the patient journey, the anxiety, like Cosimo already told you about, and a little bit peeking into the future of active surveillance, because there's a lot of things happening in active surveillance. It's still a relatively new treatment option, so there's a lot of research going on. So I would like to go back to 1993, and there was already at that point in time a publication about prostate cancer and the problems that were relevant at that time. And if you can read this text there, you see that prostate cancer was a serious disease. More than half of the men that were diagnosed with prostate cancer already had metastasis, and for those that were deemed to have limited prostate cancer limited to the prostate, there was already lymph node metastasis and the cure rate was extremely low. So this was the picture of prostate cancer in 1993 and before that, obviously. And this is the reason why we considered, wouldn't it be worthwhile to start early detection? Because obviously we are too late here and we cannot treat these men anymore. We cannot cure them. So this is the reason why we started the European randomized study of screening for prostate cancer. It started in 1991, the year that I started to work in urology. And you can see that over time, approximately 260,000 men have been randomized in Europe in 8 countries to a control arm where we do virtually nothing, only follow up. We see what happens to these men in daily clinical practice. And we had an intervention arm where we actively screened these men with the use of the PSA test and the trust-guided systematic prostate biopsies. And screening was done every 2 to 4 years up to the age of 70, and in some countries 74. So this is what we did. Active screening stopped approximately 8 years ago, and I think we have all read and heard about the results of this trial. And these were extremely favorable because we did not know this up front. Please be aware, we started this trial and we were curious whether early detection indeed could have an effect on metastatic disease and prostate cancer mortality. And it turns out with the long follow-up we have now that it has a very favorable effect of those. So we can reduce prostate cancer mortality and we certainly can reduce metastatic disease in favor of screening. But there is always a second picture and a second sentence following after this very favorable messages. And that is that also in 1993, we already knew at that time that there was a lot of prostate cancer around and that there was prostate cancer that never causes any problems and that there was no difference between treatment and surveillance already. So already at that time, we realized that when we started active searching for prostate cancer, it could very well be so that we would detect a lot of prostate cancer that would not harm the patient if left undetected and untreated, and that it might be in 2 out of 3 patients even. So this was on our radar already from the very start of the trial that we should watch this very closely. And now I would like to show you what happens when you actively start screening for prostate cancer. And please be reminded, it has very favorable results with respect to mortality reduction and metastatic disease reduction. But this is what happens when you start screening with the PSA test and the systematic prostate biopsy. I will come back to that later. You see here the screening arm and the control arm, and both are the same size, in this case 20,000 men in each arm. And you see that if you start actively screening, you will detect a lot of predominantly T1C rate prostate cancers, which are in fact for the majority overdiagnosed prostate cancers. This is a fact. We knew this already, and you can see that it happens relatively quickly here. And this is the control arm, where obviously there's also effect of screening in the control arm. So this is something we have to deal with, right? In 2004, there was a very sensible article by Chris Parker, an oncologist in the UK, and he admitted, obviously, as we all knew, that there was overdiagnosis by PSA screening, that it actually would not matter that there was overdiagnosis if the treatment had no morbidity. It would be acceptable to treat all cases, including those destined to never cause symptoms. But we all know that that isn't true, right? So we must do something about it. So the best option, at least in my view, would be that we avoid overdiagnosis. But that is very hard still today, that is very hard. Or we should reduce the harm and avoiding treatment-related morbidity. And that is something that obviously refers to active surveillance. But then immediately comes the question, what is the risk if we do not treat actively with, for instance, radical prostatectomy or radiotherapy? Because it's a very strange message often to men that you tell them, let's say in one consultation, okay, I'm sorry to say this, but you have prostate cancer. And the next sentence is, but we will not treat you actively. That is a strange message, and people will start worrying and thinking, okay, what's going on here? And then immediately, obviously, the good message of active surveillance must be there. And I would like to explain to you why active surveillance is a perfect solution for these cancers. And this is a graph which put into context mortality, survival, prostate cancer specific mortality, and the impact of treatment on certain cancers. And I want to focus, for instance, starting below in row C, as you can see here. Here you see the age, and here you see the type of cancer, time of diagnosis. And if we now focus on this particular example, you see here the example of a man aged 65. He has been diagnosed with a cancer with a relatively high PSA value, a T2 cancer with a grade group of 3, that is a Gleason 4+3. And of the 13 coils that have been taken at this systematic biopsy, 7 were positive. So this is not a very favorable picture for these men. And you can see here the orange line is survival without prostate cancer. And obviously, if you are 65 at 0.0, 15 years later, you will be 80, and some men will not get 80, right? So this is the survival curve if everything is without prostate cancer. This is the survival curve if you have this type of prostate cancer and it is not treated. So what we have here in between, the light blue part, is the potential benefit of the treatment effect. So this gap is the difference between having no prostate cancer and having this type of prostate cancer, but not treated. So this we can gain by treating this patient. And we all know that treatment is not 100% effective in all cases. So this is the treatment effect. And as you can see in this picture, there is a considerable difference between doing nothing and treating this man. So this is certainly worthwhile to treat this man with this type of cancer. If we now focus on another picture, and I go to here, to this part, this is a man also age 65, but now he has a prostate cancer with these characteristics: lower PSA, a T1C prostate cancer, a Gleason grade 1, so a Gleason 6, and only 2 of the 12 cores were positive. And now you see again the orange line, similar. This is survival without prostate cancer, and this is survival with this prostate cancer not being treated. And you see that there is a very, very narrow difference here. So the benefit of active treatment with all comorbidities is extremely small. And then there is a question of harm and benefit. And if we then take into account all the harm being done with active treatment, it is not a good thing to start active treatment in this type of cancers. So to conclude, this is a study based on more than 10,000 men with prostate cancer in the UK. And please note that approximately 50%, like I just said, in screening have these kind of cancers, as is mentioned here, with the A. And all these men will not benefit from immediate radical therapy. And for these men, active surveillance is therefore the way to go, preferably avoiding diagnosis at all. But if there is a diagnosis, active surveillance is the way to go, because there's simply only room here for harm and not for benefit. Okay? So what does it then mean if you have been diagnosed with a prostate cancer that is in principle suitable for an active surveillance approach initially? What does it mean for the patient? What does it mean with respect to anxiety? Because it is perhaps a little bit counterintuitive to not have an active treatment. I take this example of the prior study. Perhaps you have heard of this. This is a global study. And what it is actually a very interactive website to which all urologists worldwide can have a login and use this interactive website to follow their patients which have opted for active surveillance. It is very nice to work with because it generates graphs for the urologists and also very informative for the patients. For a patient, it means that if he opts for active surveillance, that he should be fit for curative treatment, because this is always an option when you opt for active surveillance, that you switch for whatever reason to active treatment. So you must be fit for active treatment. And for the rest, it's very important if you think and consider active surveillance, that you must be willing to attend follow-up visits, because it is called active surveillance. So something is happening here, and you must be willing to attend follow-up visits. And how does this look, follow-up visits? Well, let me show you. This is the PRIOS protocol. This is something that is used very often in the world and also in other settings. And what does it entail when you have chosen active surveillance as initial treatment option? It means regular PSA testing. And I know, at least in the Netherlands, and I know in other countries perhaps also, after 1 year, after 2 years of stable PSA results, often this is done by the GP. So that means that you do not have to visit the hospital every time, which is also something you rather avoid. It means rectal exams at certain points. It means nowadays regular MRIs if they are available, and if indicated, prostate biopsies, whether systematic or target, depending on the situation you are in. And I sincerely hope that it also means that prompts are being collected from the patients that are under active surveillance, because they prove to are invaluable for assessing how everything is experienced by the patients, as we just heard from the EUPROM study. And sufficient counseling. This is something that is definitely needed on active surveillance, because it needs a lot of talking, because you come to the doctor every time, you need to have reassurance that everything is okay. So I know from urologists that active surveillance actually means more time for the patient and follow up after other initial treatment options. But that's good, it is needed. And based on the data, without the MRI present, so let's say the active surveillance data from 5 years ago, approximately 50% of men after 5 years have switched to active treatment. And this is one of the reasons why there is so much research still needed in active surveillance. Not so much because it's an unsafe treatment option, far from that. It's a very safe treatment option. I hope I just showed you in the other graphs that it is a safe treatment option, but many men switch for reasons to active treatment, which are actually invalid, and we need to work on that. So active surveillance is obviously all about avoiding the complications like urinary incontinence and impotence, but also active surveillance can at some point be burdensome. I just showed you the table with all the visits you need to follow to be sure that we monitor the cancer. And what we know now from the priors is that the compliance rates for PSA visits, as expected, is very high, because that is less burden than, for instance, the prostate biopsies, because there you see a decline in compliance over time. And this is important, and not so much, I can tell you, because we are afraid that the cancer progresses, but more that there is a reclassification, because at time of diagnosis, it has not perhaps been completely in the full picture what kind of cancer you have. So that is why we do need to repeat some things over time. So what could we do to reduce this burden from active surveillance? Can we omit those prostate biopsies and to then avoid non-compliance and early dropout of active surveillance? And of course, we have all heard about the MRI, and the MRI is certainly of high value in prostate cancer diagnosis, without doubt. It has changed the whole picture of prostate cancer diagnosis. And I can tell you, and I will show you later, that it has also taken care of a lot of unnecessary testing, and a lot of overdiagnosis can be avoided. But what about MRI in active surveillance? Can we do active surveillance purely based on imaging? So no burdensome prostate biopsies anymore. And obviously these trials are ongoing. And here you see a manuscript where they have a 5-year outcome of MRI-based prostate cancer of 672,000 men. And there was an MRI done at time of diagnosis at 12 months, and one at 24 months, or even later if nothing was seen in the earlier MRIs. And it looks all very nice, but if we look in more detail, we see that in men with invisible lesions, so a normal MRI, who are still having their biopsy just because this is a study, you see that some cancers are still missed on these MRIs over time. And so we need to learn more to get this MRI in the active surveillance setting really good and trustworthy. And that is also what's being said in the literature now. It has without doubt much potential. And I think it is really a lifesaver for men on active surveillance that they do not have to have the burdensome prostate biopsies at the regular times. But we need some more work here, I guess. Then about anxiety. And I just want to stress that anxiety in active surveillance, looking at the data, the blue graphs I just showed you, you should not be too anxious that your cancer is progressing over time. It is more that we worry a little bit, like I said, that we have the correct picture at time of diagnosis. So what about anxiety in men on active surveillance? Because as Cosimo already said, it might have a psychological burden because you are not going to be treated for a cancer that has been diagnosed. And that might be very strange. And indeed, living with untreated prostate cancer can cause anxiety in patients who choose active surveillance. And we have done a lot of research on that with these prompts. And that's why I stress so much on collecting prompts, because they are invaluable to do this kind of research. And it shows that the majority of men undergoing active surveillance did not report any impairing anxiety, but it is the majority. It does not say none of the men. So there are still patients on active surveillance who report significant levels of anxiety, either after diagnosis, but for example, during the active surveillance, like I just showed you, you have to come for PSA testing, you have to wait for the test result, you have to do a biopsy, you have to wait for the test result, and this can cause anxiety. And this needs to be dealt with, and it would help enormously if we know upfront whether you belong to this group of patients who will be burdened with this. And this is why we do a lot of research on this subject, and this is why we need the prompts, because we already know that some men with certain characteristics are extremely sensitive for this, for experience this anxiety. And obviously for those men especially, it is preferable that we have a multidisciplinary team and that we can promote tailored information for these men so that we can avoid that they switch to active treatment unnecessarily. That would be a waste, because active surveillance is the right choice and it is safe. So to conclude my presentation, I would quickly go to the future of active surveillance, the improvement and the acceptance of active surveillance. And I would like to show you this figure. And this is how we did it, right? We had PSA, sometimes a rectal exam. We did a random systematic biopsy. A lot of men were biopsied. There was a diagnosis. You see the difference in amount, a lot of biopsies. Not all men had cancer, so a lot of unnecessary biopsies. We detected for the more than half the Gleason 6 prostate cancer, which we preferably would like to avoid the detection. These men went to active surveillance, certainly not all. You see the difference here. Active surveillance is a one-size-fits-all protocol, so every man undergoes the similar testing. Well, this might not be necessary in a lot of men, and we have dropout rates. But please, it has excellent results. Do not forget that with respect to oncology results. So how can we change this? First of all, that's already ongoing. Luckily, we have reflex testing, nomograms, risk calculators. We have MRI with targeted biopsy. So less men are being biopsied. And those men that are being biopsied, more have prostate cancer, so less unnecessary biopsies. We have a different balance now in overdiagnosis and detecting those cancers that need treatment to avoid further harm. We have better insight with respect to growth patterns, which men are especially suitable for an active surveillance protocol, and more men follow this active surveillance protocol. And active surveillance is about to be changed into a tailored program for the individual based on his individual risk, which we can calculate on the basis of, in this graph, only PSA, but also with MRI. And we can avoid biopsies in those men at very low risk of reclassification. And we can do a biopsy in those men at higher risk of reclassification. And if this all works and this part is already done, we are doing this now, and this is ongoing, then without doubt, we will reach a stage where we have less overdiagnosis, improved staging and grading, and a personalized active surveillance protocol. And this all will lead to less anxiety and increased acceptance and adherence to active surveillance, which in the end will make active surveillance even safer than it is today. And with that, I would like to thank you and show you where I work at Erasmus. I moved a few years ago from this old building here in the middle to this very new building here on one of the higher floors. And this is my view from my window in the office, which unfortunately I have now not been able to visit for a year, but hopefully I can go back pretty soon. And thank you for your attention to this presentation. Thank you very much.
Thank you very much, Monique. It was very good, your presentation, and also the one of Hendrick. We see a nice picture of your view from the office, the nice sky, blue sky. Okay, so I thank you everyone for the participation. I don't know if Anja has some online questions.
Yes, I received some, Cosimo.
Yes.
The first, should Gleason 6 even be considered cancer?
And for whom is the question?
Cosimo,
Yes.
do you prefer somebody to answer the question?
Maybe, I don't know, if, I think both
Dr.
can
Van,
answer.
it's
Maybe
for
Eric.
Dr. Van Poppel. It's for Professor Van Poppel.
Yeah, I'm happy. I'm happy to take that question. You have seen that in the slides that I have presented, we are speaking about grade 1 and 2 and score 2 and 4. These are not considered cancer any longer, as I said, and they are not mentioned in the pathology report any longer. There were so many years ago, and this is when we had the diagnosis of cancer on a biopsy in the late 80s. Prostate cancer was a killer, so we treated them. These we do not consider to be cancer. Gleason 6, we have extensive research done in Europe, also done in the United States. There are some patients that were operated for Gleason 6 that so-called then subsequently developed progression and had a risk of dying from prostate cancer. But you need to go back then to the pathologist that has made the initial diagnosis. We are now with the international guidelines on classification of Gleason score much better. And when today a pathologist tells us this is a Gleason 6, it will be a Gleason 6. But you understand, what is the difference between a 3 plus 3 and a 3 plus a little bit of 4, or what is missed on biopsies? You have always a likelihood that you miss something on biopsy because there is even more aggressive tumor that is not seen on MRI, that is not targeted and not picked up with systematic biopsies. So the man who has a Gleason 6, to say that he has no prostate cancer, because when it's only this what we see under the microscope will not kill him, is probably a bridge too far, because the likelihood that he has some more cancer elsewhere. So this is why we need this safety net in all active surveillance patients with a Gleason 6, that this is checked by regular PSA testing, that this is checked eventually in case of PSA rise or short PSA velocity by a multiparametric MRI, and eventually rebiopsied to see that he does not need to be reclassified.
Thank you. Thank you, Eric. Any other questions? Questions from online?
Yes, I have a question for both our speakers. What is the European view of genomic testing used to determine with other factors whether a man goes on active surveillance?
Okay.
Monique.
So what? Yes. So what is the use of genomic testing, of the value of genomic testing?
Yes, the European view of genomic testing.
Okay. Well, I'm not particularly aware of the European view, but in my view, genomic testing is indicated in a certain subgroup of men, those with BRCA. How do you call it? BRCA. I cannot remember the word, but either for BRCA mutations, and also those men with family members who have been diagnosed with prostate cancer at a young age. So really those men that have a high risk of having aggressive cancer at a younger age. But in my view, at the moment, genomic testing is certainly not something that should be used in every man that is being considered at risk of having prostate cancer. That is one step too much in my view. But Hein, please go ahead if you.
Yeah, I should add something. There is just a recent paper. I think I saw it just a couple of weeks ago. It's a large analysis, and they have seen that the application of active surveillance, and in this group of patients on active surveillance with genomic testing or without genomic testing, to see whether they were safe to continue on active surveillance, we must realize that more men choose to stop active surveillance because of the result of genomic testing. So this will have disadvantages as well. By the way, they are not easily accessible today. They are not available everywhere. I do not want to include genomic testing just besides the BRCA1 and 2 mutations. This is different because this is really young men, 45 years of age, that are at risk to develop significant cancer. But the real genomic testing to know, am I a safe active surveillance patient that can continue? I think we do not have enough data today. It might impact negatively on the number of patients that want to continue active surveillance. And I think the science is not there yet that this is the correct way to go.
Thank you. Other questions?
Questions are running in.
Oh, yeah.
Where to begin? So let me ask another one. What happens with high-grade PIN? Does it turn cancer or can it regress?
Does it turn cancer or can it regress? Oh, interesting. Well, I think it can remain high-grade PIN, and it is considered to be a stage before prostate cancer. But whether it can regress, I'm not sure. Perhaps Hein knows that, but I'm not sure.
We have studied high-grade PIN very intensively in the past, and we have today agreed not to mention high-grade PIN in biopsies any longer, because there is no real roadway from high-grade PIN to cancer. So this means that many men can have high-grade PIN and continue to have high-grade PIN. And we have seen by giving dietary measures and supplements that high-grade PIN can even disappear. So I think the question is very relevant. I do not consider high-grade PIN to be cancer. We are not sure that it is a precursor of cancer in every patient. So I would try to convince all the pathologists that look at biopsies not to mention high-grade PIN because it's just a factor of fear. On the other hand, if you are on active surveillance, can you do something to maybe not have your cancer grow too fast? And then we are thinking about prevention of prostate cancer. The only data we have is epidemiologic data. If I have a young man who comes to me and says, my father, I saw him dying from prostate cancer. I do not want to have prostate cancer, but can we prevent it? No, we can certainly not tell you black and white that you can prevent it, but you can adapt your diet and your lifestyle. You can do more like Southern Europe. You can do more like the Asians. There is supplements that you can take. We know that processed meat and red meat probably are a cofactor to get prostate cancer. So there's a lot of things that you can do. And we have in high-grade PIN patients administered Prevalon a couple of years ago, which was a soy supplement with vitamin E. And what we saw is that there were not less patients developing prostate cancer than in those that did not get it. The only thing we saw that there was a response in PSA. Yeah. And those who responded with a lower PSA by taking these food supplements, they indeed showed to have less prostate cancer in subsequent biopsies. So there is something that could be done, but I say it's all very floppy yet.
Not too strong evidence.
Not too strong evidence.
Not too strong. But we also did a randomized trial and we saw the same, that it affects your PSA doubling time. So that will be longer, right? So it affects your rising of your PSA. And that we assume also affects your tumor growth. But that is something that still needs to be proven. But yes, and in the end, it doesn't harm to have a healthy diet and to exercise a lot for many, many other reasons.
Absolutely, absolutely.
Other questions?
I have another meeting already starting,
Yeah.
so if there is a question for me, then I would like to have it.
Yes, Professor Poppel, I have one from our. You told us that 50% drops out after 5 years. Yes. What can those figures be with all the changes?
Great. I just typed it back to Andre, but that was a wrong mistake to type it back to everyone. So I will read my my answer to Andre. I thought I sent it to everyone, but that's my mistake. I think it hopefully will be much, much lower, since the diagnosis will already be much more accurate in the future, as I hopefully have shown you with the MRIs, with the more pathological knowledge we have. So the fear of reclassification, especially in the first year on active surveillance, there is a dropout of approximately 25% already, which drops out after 1 year. And that is not because of progression, but because of reclassification. And that will disappear in time. I'm sure of that, because we will do at time of diagnosis a much better staging and grading. Then the anxiety is a main reason for over time that men or the urologist is not always the patient. It can also be the urologist who is anxious to follow up with the protocol. And I hope that we can address that further with the prompts and with the counseling that we need to do. And also urologists need to be counseled how to best provide active surveillance treatment to the patients. But in the end, I will hope it will drop down to less than 20%. And that is what I just sent to Andre, but now for the whole group. Okay.
Thank you, Monique.
Okay.
You can leave us.
Thank you. I'm very
much.
sorry, but I have a pioneer meeting starting at 7.
No,
I have to be there. So
we
okay.
will keep you. We'll keep in touch in case we will send you other questions in the.
Oh, no problem. Please do. Please send me the
Okay.
questions.
Okay.
Yes, no problem. Okay.
Thank you very
Bye-bye
much. Have a
all.
good evening.
Bye, Monique.
Bye-bye. Bye-bye.
Bye bye. I do, Anya, you have many questions or?
Yes, let me just ask one question to Professor Van Poppel. Is there research indicating young boys should be monitored when PSA is no higher than 1?
Yeah, there is an age-related PSA. And you know that what we consider to be too high in young men, the fluctuations of PSA by intercurring diseases like prostatitis, like biking, like ejaculation. A young man who goes on holiday for the weekend to the Ardennes in Belgium, and he's biking for 6 or 7 hours and makes off 3 or 4 times, he will have a higher PSA on Monday morning. So there's so many different things that can happen. I think there is an age to take a PSA which should not be lowered below 40 years of age. For the EAU, it's 45 when you have either an African origin, if you have a family history, that's a first or a second degree family member who has had prostate cancer. And third is the BRCA2 mutation. BRCA1 is still not so closely related to prostate than to breast cancer. And this is 45. I know that younger men, sometimes they have a PSA determined, and it gives very difficult stories because they have a PSA of 1.7. Then they go for an MRI, which is not done always in a proper way. They are anxious to have prostate cancer. On the MRI, you see something that is then misinterpreted. They could even have biopsies, which I believe if you look at the incidence of significant prostate cancer, we should stick to these ages that I just mentioned and not do PSA testing in younger men. Prostatitis can give PSAs up to 70 to 80. Benign prostatic hyperplasia, the big prostates, obviously they have a higher PSA as well. And therefore, why do we start at 40, 45? Because these men do not yet have significant prostate enlargement. Because once you have prostate enlargement, just the size of your prostate will make that you have more PSA in your blood. So therefore, 40, 45, if a man does not want to die from prostate cancer today, he can do it. And then he should follow what we have said, have his first PSA 45 or 50.
Okay, thank you, Professor Van Poppel. I have just one last question and then we can finish. Can you comment on having a confirmatory MRI in addition to a confirmatory biopsy to act as a double confirmation for a Gleason 6, considering active surveillance?
Well, again, this all depends. And we are working, Monique and I are working in tertiary referral centers. And it happens that the patient has had an MRI, even in private somewhere in Antwerp or Brussels, that he had 1 or 2 biopsies from his prostate. And he is then considered a PIRATS 3 or 4, let's say, but he has only one core that is involved for less than 50%, and he's considered suitable for active surveillance. I think this is correct, but you need to be sure about the initial status of the patient. Is this MRI well done? Is the biopsy well done? And if it isn't, then I think it is wise as a man confronted with a so-called active surveillance candidate to have a confirmation in a center of excellence with a decent multiparametric MRI and eventually a rebiopsy. And this is unfortunately what happens if we see people that are worried and that have been seen in a peripheral or in a small hospital, candidate for active surveillance. Am I safe to do so? Then often we have to propose a new MRI and to do new biopsies. Actually, if you start active surveillance and you plan to only check the situation and the evolution 2 to 4 years later with an MRI or a biopsy, you need to be sure from the beginning that you're not on the wrong track.
Okay, thank you very much for your answers, and I think we can take the commitment to answer to this to the remaining answer in the next webinars. We will have a next one on May 20. Will be another testimonial and other 2 medical specialists. The idea is to have more and more opinion and to continue exchanging ideas and indication on this information on these evolving items. So thank you very much, Hendrick, for your support. And thank you to everyone.
May I just ask one question?
Extra.
Thank you very much for very nice lectures for both of you. I'm interested to know now we have quite few men under active surveillance. So what would be a realistic future? How big portion of men should be active under active surveillance compared to men under active treatment? What is behind your estimation for
You want me to estimate
the future? For the future, I mean, what is the goal?
Well, Pentti, you understand what we are trying to do at the European Parliament and at the Europe's Beat Cancer Plan, and what ECHE has been achieving in Austria is wonderful. We try to do the same in Belgium, but we know that if we will do early detection the way we are proposing it, there will be overdiagnosis, and we then need to be sure not to do overtreatment. Asking me what percentages of men will be on the one or on the other side is very difficult to say, because today there is no population-based screening done. What we propose to do with the EAU and at the Parliament and in the European Union is to have a population-based information campaign, after which the man chooses to have a PSA test. And starting with the PSA test, then we will do the next steps as we have described. But I do not have the slightest idea how many will still be overdiagnosed, but there will be. So the better we can have active surveillance secure, and the better it will be for the early detection programs, because men will be less reluctant to have a PSA test if they know, maybe I have prostate cancer, but it might even be that I do not need to be treated. So I think that Cosimo has had this idea from the very beginning to support. Why did he come and talk to me? Because I'm mostly busy with this early detection program. He was busy with active surveillance, with ASPRI and with his friends over there. And he has said, I can help you in making early detection more acceptable by just telling that active surveillance is a good management for a certain amount of patients that are diagnosed with prostate cancer.
Yes, I think we will have to go on this in the next webinars, because it's a very interesting subject. And so I am sorry, but we have to end now. But I want to thank you everyone for taking part of this webinar, and we will try to go on with the next one on May 20. Thank you very much. In any case, you have our email address if you want to send other questions. Thank you very much. A good evening to everyone.